Hello, everyone. This is Kelly Helm with Nephrotic Kidney International, and I just want to welcome you to our Ask the Expert webinar series. Today, we're going to be talking about nephrotic syndrome 101. And for those of you who are new to NephCure, I just want to talk a little bit about our focus, which is to engage a broad community of patients with the diseases that cause nephrotic syndrome, their caregivers, their doctors, scientists, and the biopharmaceutical industry to raise and leverage support, funding better treatments, and hopefully one day a cure. Before we get started, I do have a few housekeeping items I want to discuss. I do have everyone muted just to reduce the feedback that we hear in our microphones and our phones. And we will have a Q&A session at the end of the webinar. And if you do have questions, I encourage you to type them in. You can go to your GoToWebinar toolbar, which is usually in the top right-hand corner of your screen, and you can type questions in there. Also, if you see the little tab on your toolbar, the little hand icon, you can press the hand icon and raise your hand, and then I can unmute you individually. Sometimes, depending on feedback, we might just go with the typed out questions, but we will get to your questions, so you can go ahead and type those in. And with that, I would like to introduce our expert guest speaker, Dr. Mindy Banks, who is a pediatric nephrologist here in Denver at Rocky Mountain Pediatric Kidney Center. She also is an internal medicine doctor as well as an adult nephrologist. So we're so happy to have you, Dr. Banks, and we appreciate you being here with us.
Hi, everybody. Can you hear me? Kelly, can everybody hear me?
Mm-hmm. Yes,
okay.
We can hear you.
All right. Okay, great. So we'll go ahead and get started on this talk about nephrotic syndrome 101, just by going over what the kidneys do. So I think most people know you have two kidneys in a normal human being, and our kidney process the blood and excrete the waste and extra water and make it into urine. So our two kidneys are drained after the urine is made into the ureters. Those are two tubes that are connected to each of the kidneys. You can kind of see that on the screen here. They drain into the bladder, and then the urine leaves our body out the urethra. So healthy functioning kidneys are important not just to get rid of fluid and get rid of urine, the wastes in our urine, but they also help eliminate things that we ingest. So if you have your Tylenol or your aspirin, there are metabolites that come from that, and we need our kidneys to get rid of those metabolites so we can stay safe when we're taking those medications. They also regulate electrolyte concentrations such as sodium, potassium, and chloride. We already talked about regulating the amount of fluid within the body and helping to maintain blood pressure, but also acid-base status. They help make sure that we have enough base in our blood so that we can grow and have good bone health. And then they actually make hormones, and I think a lot of people don't think about that. But one of the hormones that our kidneys make is called calcitriol. It comes from vitamin D, and that helps keep our bones strong, in addition to hormones that help maintain our blood pressure. Go ahead, next slide, Kelly. So here's the anatomy of the kidney, and if you look over at the kidney, there's this black box, and it's circling the parts of the nephron. Excuse me. So each kidney, if you develop until term and are delivered as a term baby, has about 1 million nephrons, and the nephron is composed of the glomerulus and the tubule system. So the glomerulus is the filtration part. It's a ball of capillaries, which are teeny little blood vessels, and the blood goes in and it's filtered, and then the filtered blood returns to the body. The filtrate then is processed further by the tubules, and if we didn't have that, then we would lose all of these small molecules and electrolytes that we need to maintain life. So it's a pretty intricate system. It's a little bit more than a sieve. The tubules then go on to collect the urine, and they all converge into one big system here, eventually the ureter, and that's what leaves our body as the urine. Go ahead, Kelly. So these are pictures that I really love. I think the kidney is so beautiful up close. If you look all the way over to the right, this is kind of where the magic happens, that little octopus-looking structure there. This is the podocyte, and this is the head of the podocyte where the P is. And the rest of it are its arms or legs, and off of that come these further digitations, and they interdigitate with the podocyte next door. And that's what the picture looks like over on the left, is showing those little kind of Smurf-like looking caps there. Those are called the podocytes, and those are the little foot processes that come off of the podocyte cell, or that octopus that we were looking at a second ago. And again, they interdigitate with the neighboring cell, and they form this intricate network here. So blood is filtered. So the blood side is on the red, where the red is there. Those endothelial cells come from the capillary. And then blood goes through and passes the glomerular basement membrane. And then it has to pass these podocytes. And so the podocytes are really the last stop, and the last control mechanism to keep wanted things into the bloodstream. Okay, go ahead, Kelly. Again, another view of our filtration barrier. The red part here down below is going to be the blood. And you'll see in the diagram, we've got a red blood cell here, and we've got albumin, and those are two substances that we want to keep inside the bloodstream. So the albumin is one particular type of, it's a small protein, and it actually acts as a sponge and hangs out in our bloodstream to hold on to blood, hold on the fluid into our blood or the plasma. If we don't have that albumin, then blood can leak everywhere else in the body. And so we really want to hold on to that. And you'll see in the intact filtration system over here on the right, the albumin can't get through those, that filtration barrier there, or through the podocytes. Then if you look over on the right, I was talking about the left picture, then if you look on the right side, this is what happens in nephrotic syndrome. These foot processes up here on the top with the green, they become flat. And when they're flattened like that, they don't have the same structure, and they can't hold on to the albumin. And so instead of the albumin staying into the bloodstream when the urine is filtered, or excuse me, when the blood is filtered and made into urine, the albumin leaks out into the urinary filtrate, and that eventually then gets out the body by the urine. Okay, go ahead, Kelly. So there are many ways to look at it. You know, this slide likes to point out that it's like a colander with maybe some spaghetti or something into it. I like thinking of it like a sieve with some sand in it, because the sand would represent the small molecules like albumin. And then the sieve is our glomerulus, or our filtration system. And then if you have, you know, a water hose or some type of pressure system that's being squirted over the sand and over the colander, or over the sieve, you know, you want to keep as much sand in, right? But if those holes get bigger and they continue to get bigger, then you're going to have more sand drip through out of the sieve or out of the colander. And again, that's what happens with nephrotic syndrome. Yeah, next slide, sorry. So again, nephrotic syndrome, a condition in which protein, in particular albumin, leaks from the blood into the urine. So if it's being leaked into the urine, that means that there's less of it in the bloodstream. If there's less of the protein in the bloodstream, then you don't have those little sponges I was talking about. And so the fluid that normally stays in our plasma or in our blood leaks out into the tissues, and that's why you get fluid overloaded. You get fluid in the lungs, in the belly, in the eyes. And I guess we'll talk about that more on the next slide, because it does then lead to another cascade of events that constitutes nephrotic syndrome. The damage can be related to an unrelated condition like diabetes. So in individuals with diabetes, you spill a lot of sugar through those filtering units because you have so much sugar in your bloodstream. The problem if you spill all that sugar is it damages the filtering units and then results in leakage of other things like albumin. Hypertension, there's so much pressure against those filtering units that you have more leakage of sand. You have more leakage of protein like albumin. So these types of conditions are secondary, they're unrelated to necessarily the kidney itself. The second type is a primary or idiopathic problem, and that's where the damage is from a kidney disorder. So something intrinsic to the kidney is what's leaking to the protein being spilled. Okay, now we get on to what I started to talk about earlier. Again, you lose the albumin. When you lose the albumin, you lose those sponges, and the fluid starts leaking everywhere else, and it causes edema. The protein is in the urine, so that's what proteinuria is. And when you see protein in the urine, if you weren't to dip it, but you could tell that there's protein in there because it looks kind of foamy. Hypoalbuminemia just means that, again, the albumin's in the urine, so it's not in the blood, and the blood levels are low. Hyperlipidemia, we don't understand completely, but we think it has to do with the fact that albumin is made by the liver, and if your liver notices that the albumin is too low, it starts trying to crank out more albumin to compensate for that. And in the process, it kicks out more cholesterol as well. And so we can see incredibly high cholesterol levels in individuals with nephrotic syndrome. So again, if you have all this cholesterol in your bloodstream, where is it going to end up? It's going to be spilled into the urine, and you can get lipiduria or lipids in the urine as well. Now, you don't just lose the lipids where there's too much of it, albumin because the filtering unit is leaky. You lose other substances in your urine too, and some of those substances help prevent blood clots. These are anti-clotting factors that we have intrinsic in our blood, and you lose those in the urine, and if that happens, then you can get blood clots, so it's not uncommon sometimes for people to be initially diagnosed with nephrotic syndrome because they've had a blood clot. You also lose proteins that are important in fighting infection, and so you know, a long time ago when children and adults would get nephrotic syndrome, they could get really, really sick with infections because we didn't have all the great antibiotics and immunizations that we have today. So those are also complications that are part of this whole nephrotic syndrome. Go ahead, Kelly, next slide, please. So one question I get all the time is, what's the difference between minimal change and FSGS? Minimal change is the classic nephrotic syndrome that we see in children, and it's characterized by normal appearance of the filtering units under the light microscope. So when we do a kidney biopsy, and we tend not to do them in children as much anymore because we've got a lot of data to suggest we don't need to do that. But when we did do a lot of kidney biopsies in kids, we noticed when we just took the kidney tissue and cut it up and looked at it under the slide, just the regular light microscope, everything looks totally normal. And that's where the name minimal change disease comes in. You've got significant findings, clinical findings of nephrotic syndrome, but under light microscopy, there's no change. There's minimal change between that and what a normal filtering unit looks like. Now that we have really high-powered electron microscopes, we can see that there is injury, particularly at those foot process level, where you've got that effacement or the flattening of the foot processes, and that's what we looked at a little bit earlier. The difference between this and FSGS, because FSGS shows this as well with the foot process effacement, is that in FSGS, there's actually there are small areas of scarring, and you can see that on the bottom right picture with the purple, in that the glomerulus actually has an area that's scarred. And if you have where the filtering unit is, where the capillaries are, then that impairs kidney function. And so that's the main difference, is that FSGS, if it progresses and continues, that you have ongoing scarring and ongoing kidney function, whereas in minimal change disease, remissions happen commonly, and they allow the filtering unit to heal, and so loss of kidney function over time is uncommon. Okay, Kelly, go ahead. So again, this is just another picture, just a regular light microscope. Normal is all the way over on the left, and you can see, you know, this beautiful glomerulus here, this ball of capillaries that's kind of cut in half on this picture. And you see these little white spaces. Those are the capillary loops that are nice and open, which is what we want them to be so that filtration can occur. In the middle slide, this is minimal change disease. Essentially looks the same as the normal. And then all the way on the right, you can see kind of this clump of pink, and that's scarring, and that's FSGS. So the most common forms of primary nephrotic syndrome in children and adults are essentially the same. It's a similar list. I don't want to say it's the same, but it's a similar list. It's just they happen with, the different types happen with differences in frequency. In adults, we used to say that membranous nephropathy is the most common type. Focal segmental glomerulosclerosis, or FSGS, which we just talked about, is really on the rise, and in some populations is even higher than membranous nephropathy. But other forms still include minimal change disease, not uncommon on the list. Alport syndrome, which is hereditary, also associated with hearing problems. C1q nephropathy, IgA nephropathy, IgM nephropathy, and then some more rarer causes like membranoproliferative glomerulonephritis or MPGN. In children, the vast majority of the time, they will have minimal change disease. Then coming in next is focal segmental glomerulosclerosis, and then the list of the other forms is essentially the same as in adults. But you also have to add on their congenital nephrotic syndrome. Sorry, Kelly. Just the congenital nephrotic syndrome is on this list, and that usually happens within the first year of life. Okay, go ahead, next slide. So a checklist of things to discuss when you see your nephrologist. Obviously the diagnosis, so that you understand what's going on, why it's happening. As far as the extent of damage, sometimes it's a little bit difficult to talk about because we often don't do biopsies in children. And that's because in the 1970s, when we were doing a lot of initial research in children with nephrotic syndrome, they all got kidney biopsies, and we found that the prognosis was not determined based on what the biopsy showed. If you had FSGS or if you had minimal change disease, it didn't really matter as long as you had a nice, quick response to prednisone. Your prognosis was much better than someone who did not. And so that's why in children, as long as you continue to show a nice response to prednisone, we tend not to biopsy. But in adults, it's common to biopsy. More common to biopsy, and that can tell you if there's scarring, and if there is scarring, how much. Then, of course, treatment options, and I would say most of the questions really surround that because the medications we use have a lot of side effects, and I think that's one really important thing to remember is that we're not treating an ear infection. We're treating kidney disease, we're treating kidney failure, and so these medications have a lot more side effects, a lot more interactions. But they can be very safely used, and they can be used very effectively. So other things that we talk about, diet, exercise, and lifestyle changes. I would say obesity is a really big one, particularly in FSGS. If you can modify that and have even just a moderate to mild amount of weight loss, that can actually improve prognosis. Then what to do if symptoms get worse. I think that's always important to have a plan of when you're supposed to call and when you're supposed to worry and when you're not. And then, of course, what to do in an emergency situation. So in addition to these things for pediatric patients, and I would say for adults as well, discussing vaccinations is really important. We don't usually recommend the pneumococcal vaccination as far as certain types of the pneumococcal vaccination. You get the little ones when you're kids, like the Prevnar, but the Pneumovax is a vaccine that usually elderly adults get, and that is actually indicated in children with nephrotic syndrome as well, because we know one of the most significant and severe pathogens in nephrotic syndrome is pneumococcus. And then we kind of discussed this already, but is a biopsy necessary? And in children, the vast majority of the time it is not. And then just as another important point to make is that, everybody's always entitled to a second opinion. Unfortunately, unlike other conditions like hematology or oncology, where there are consortium groups that really guide what you do because you get enrolled, everybody gets enrolled into a study. In nephrotic syndrome, we don't have that. And so once you start falling outside the normal kind of categories of prednisone, infrequent relapser, and we'll talk about more about that in a minute, then each patient is individual, and so there are many ways to do things. And if you're not comfortable with your treatment plan, then it's always you always have the option of seeking a second opinion. Okay, next slide, Kelly. So treatment goals. In the short term, obviously we want to get rid of the proteinuria, or at least reduce it as much as we can. The more proteinuria you can reduce or get it back to the normal range, the better the prognosis. Then we want to improve clinical symptoms, especially the swelling, which can be very life-limiting, and then correct the abnormalities. The cholesterol and the albumin, usually they correct themselves when we fix the nephrotic syndrome. But sometimes we can't fix it completely, but we can mitigate it. And those are important also prognostically. Then long-term, you want to prevent recurrences of the protein spillage in the urine, of course, preserving kidney function, and then avoiding treatment-related complications. And I would say the biggest thing is trying to limit the amount of prednisone exposure. Next slide, Kelly. So the treatment of nephrotic syndrome, number 1, number 2, and number 3 is always going to be prednisone. And that's because it works. We know that in people who respond frequently to prednisone, they have a much better prognosis than someone who does not. If you do not respond to prednisone within the first 4 weeks as a child, then it becomes a little concerning that you're going to be steroid resistant. The vast majority of children who are going to respond to prednisone, over 90% respond within that 4-week time frame. If you go beyond 6 weeks, then that's when it's really concerning in my mind that you're not going to respond to prednisone. For adults, a lot of times they'll go a little bit longer on the high-dose prednisone, up to 3 months, before really declaring steroid resistance. If you don't respond to steroids, there are other options, and you can either add other medications to the prednisone to try to hit the problem from multiple angles, or you can substitute it for something else. But obviously, it's going to be up to you and your doctor to really sit down and hash out a plan and discuss the side effects that can occur with these other drugs, compare them to that of prednisone, and see what's going to work best for you. As in all types of medicine, it's important to talk to your doctor about clinical trials, but I have to say with nephrotic syndrome, there's not a ton out there right now. And I do want to kind of back up and just say why prednisone, we think prednisone helps. And it's because actually the problem is not necessarily with the kidney. It's not like you're born with a kidney problem. We think the problem lies in the immune system. And the immune system, when it gets activated, makes a nephrotic factor, a nephritic factor, that then affects those podocytes. And when it affects the podocytes, they can't function properly, and that's when you start spilling protein. So that's why we think the prednisone helps, because it dampens the immune system. When it dampens the immune system doesn't make this nephrotic syndrome anymore. So that's why these immunosuppressant drugs work. Okay, Kelly, next slide. So other treatment options, there's a whole list over here in the green box of other common therapies. ACE inhibitors, ARBs, are types of blood pressure medications that preferentially decrease the pressure inside the filtering units of the kidney. And if you decrease that pressure, you're going to decrease protein spillage in the urine. Cytoxan is a chemotherapy agent that we actually give orally in nephrotic syndrome. And besides prednisone, it's really the only other FDA-approved medication for nephrotic syndrome. All of the other medications are used off-label. Cyclosporin and tacrolimus are brother medications. They're both called calcineurin inhibitors. We use them commonly in transplant. Mycophenolate, which is also called Cellcept or Myfortic, is another option. Rituximab is an antibody, and it's an infusion, and it works actually in an entirely different way as the other medications we think attack the T cells, whereas rituximab attacks the B cells, which are different arms of the immune system. And I think that really reinforces that we don't know exactly what's going on with the immune system, and that it differs for different people, because these medications really do work differently. The last one is Axar. It's actually a really old medication for nephrotic syndrome. It's ACTH, and it will stimulate your adrenal glands to make its own steroids, and it can be effective as well. So for the clinical trials for both children and adults, abatacept is one of the newer ones. Sparsentan is another one of those blood pressure type medications that can be helpful. And then, we always have to talk about complementary therapies as well. I do have patients who try acupuncture, acupressure. I think anything that's going to help alleviate stress can be helpful. Various supplements, fish oil might be one that in any type of inflammatory type condition can be helpful. And then diet and lifestyle changes. We already talked about weight loss, which is probably one of the more powerful lifestyle changes that can be helpful in proteinuric states. And then diet, you're going to have to be watching the salt too, can also help with symptoms. Okay, Kelly, next slide. So there are many factors that influence long-term outcomes, and there's a whole list here. I would say the biggest ones are going to be responsiveness to treatment. So again, and I mentioned this before, the quicker you can respond to prednisone, the better we know that your prognosis is going to be. Of course, the degree of ongoing proteinuria, not necessarily the degree of proteinuria at diagnosis, but the longer you have the protein in your urine, the more chances are there's going to be actual scarring to the kidney. And then age of onset is important as well. The older you are, kind of after the age of 8, the higher likelihood that it's going to be something other than minimal change disease. And then also the younger you are. So if you're less than a year of age, the concern is always brought up that maybe you have one of the congenital forms of nephrotic syndrome. So what do we know? And that's, I alluded to before, that every patient has a unique journey. The good news is that most pediatric patients with nephrotic syndrome have minimal change disease. And so therefore we don't need to do kidney transplants because end-stage kidney disease is pretty rare. And that most people with minimal change disease respond very well to initial therapies. For many glomerular diseases, however, remission can take longer, and I definitely have seen people show a response initially and then have it take, a good year or even longer to really achieve complete remission. Next slide, please, Kelly. So in summary, nephrotic syndrome is characterized by protein in the urine, and we talked about the signs already. Of course, you can get fatigue, the swelling, the weight gain, the foamy urine. And this protein in the urine signifies that there's damage to the kidney and that the filtering units are not working properly. The treatment is always to reduce the proteinuria. In order to do that, we need to lower the blood pressure. And if we can do both of those things, we're going to be preserving kidney function. Of course, each therapy has its own risks and side effects, and so it's important to really make sure that you have a good amount of time to sit down and talk with your doctor so that you can have an open and honest conversation about what you as a team can come up with to limit side effects and improve efficacy. Lifestyle changes are also important. And then, the last thing is prognosis can vary depending on each patient's situation. Okay, Kelly, next slide. So that is the presentation, and I encourage you to submit your questions. Thanks for listening.
Thank you, Dr. Banks. So we did have a couple of questions come in, and I'm just going to go ahead and read them, and we'll kind of go through one by one. The first one is, what are the things to keep in mind for a patient who is transitioning from being a pediatric patient with nephrotic syndrome to an adult with nephrotic syndrome?
Yeah, that's always a hard one because usually patients who are in that transition age range, they've been dealing with nephrotic syndrome for a long time. And so you want to be sure that you're transitioning to a doctor that has some experience, I would say ideally with the pediatric side of things. I'm a med-peds doctor, and so that's what I've been trained to do. But certainly there are other doctors out there, you don't have to be med-peds trained, who are used to dealing with a young adult or someone who's transitioning, because it really does take the whole family. Parents have often been involved since childhood, and they can't just, from one day to the next kind of be excluded on the conversation. So you need to find a doctor that you're comfortable with and someone who's comfortable taking care of a young adult who has, kind of a whole family or village mentality versus in the adult world where, oftentimes, families and sometimes, but you don't often have both your parents and everybody in there with you as an adult trying to come up with a treatment plan. You also need to really make sure that before you actually make the transition that you're preparing this young adult for making the transition, just starting to learn their medications so they know what they are and they aren't constantly looking for their parent for, the medication list, maybe even keeping the list or at least pictures of their medications on their, in their phones, because most young adults always have their phones with them. Making sure they know, contact numbers, who to call in cases of emergency, if they're away at college or, off on their own instead of, just relying on their parents to kind of do that stuff for them. And yeah, I mean, I think, again, really trying to find a doctor that fits what you need as a family and will be able to sit down and review things with you, because oftentimes when you're making that transition, you've already been on a really long road, and so you're going to need someone who can sit down and take that time with you.
And I'd also like to add, we do have an Ask an Expert webinar specifically for transitioning from a pediatric to an adult nephrologist. So I will email out the link to our YouTube channel where you can find that specific webinar. Okay, another question is, what do you think about gene splicing?
So gene therapy is a really interesting question. As far as I know, gene therapy is not, there is no gene therapy for nephrotic syndrome at this point, but it's on the horizon. It's kind of like the question of bone marrow transplantation in nephrotic syndrome as well, because again, if we're talking about white blood cells and our bone marrow function and that kind of stuff, potentially bone marrow transplants could be helpful. But right now, it's just not, we're not there yet. I do think, particularly in the genetic forms, that and maybe all of this is genetic, we're finding out so many things are actually genetic, that maybe in the future that might be on the horizon, but for right now, unfortunately, from what I know, there are no options for that.
Okay, kind of along that line, any potential use for stem cells?
Right, so it's a similar question. I mean, I think there's a lot of potential for research in stem cells, and again, in the United States, a lot of times that actually means the stem cells that are obtained at the time of delivery from the umbilical cord. And I think there's a lot of potential there, but we just haven't tapped into it from what I know.
Okay. Next question I have is, have you seen a correlation between children with nephrotic syndrome and other autoimmune diseases?
For sure. I would say, even if we're considering, eczema, allergies, that kind of stuff as being along the autoimmune type spectrum, it's definitely an aberrancy in your immune system. Those are commonly associated with childhood nephrotic syndrome. As you get older and you start delving into the other types and the other causes of nephrotic syndrome, there definitely is association with other types of autoimmunity. So right, I mean, we know that people have proclivities for immune-mediated problems, and nephrotic syndrome is on that spectrum. And a lot of times if you have one, there could be an increased risk for having others.
All right, another question is there generally a difference between the initial prednisone treatment and the treatment of relapses, say in length or dose?
There is, for sure. So the initial, getting someone into remission usually involves a standard high-dose prednisone. Initially, we usually treat over a good 3 months. Initially, the 6 weeks of the high dose and an alternate day lower dose prednisone, and then some will stop it there, and then others will wean it off over the next couple of months. With relapse, we try to, minimize the steroid exposure, and so often we're not going to do that full length of steroids, and so we'll just get you into remission, and then after about 3 days or so of being into remission, which is dipping negative or trace on the urine, then we'll start to wean that prednisone, kind of depending on where you are in your course. With initial, if you're an infrequent relapser with initial relapses, oftentimes you'll just get that every other day steroids for a month, and then you can stop it or you can wean off of it. But then, once you start falling into other categories, such as a frequent relapser, steroid dependent, then the steroid courses really are individualized, and a lot of times up to the preference of the provider as well.
Great. This is a good question, I think. Onset, what are the considerations, for those with onset in their teenage years, such as age 13, in terms of genetic testing, biopsy, like what's kind of the age where they kind of start to fit into the adult protocols more so than the child?
So that does depend on clinician preferences. I personally at age 13 would biopsy that child. I wouldn't do necessarily genetic testing unless I knew that they were steroid resistant regardless, because oftentimes, quite frankly, it's difficult to get it covered by insurance, and it's a huge expense to families, and it doesn't really matter if you're responding to the steroids. And so after the biopsy, if you don't respond to steroids, that's when I would consider the genetic testing.
Okay, thank you. And let's see. What is the long-term prognosis for a child with congenital nephrotic syndrome?
So congenital nephrotic syndrome is a much different beast, and that's because you're dealing oftentimes with an infant or a baby who has nephrotic syndrome, and you can imagine trying to manage fluids and electrolytes and diuresis in an older child and a baby who's just drinking formula and trying to grow. That can be even more challenging. And often children with congenital nephrotic syndrome have massive degrees of protein in the urine to the point that they just can't sustain their blood volume. And so these children are often requiring significant amounts of albumin, and even with albumin infusions have trouble with that. And so these children a lot of times will have to have their kidneys removed just to try to eliminate the amount of protein that they're spilling in their urine. So it's definitely a different beast and can be much more difficult to manage just because of the massive amounts of protein that's being spilled, and also the age group too. So it's fraught with complications and difficulty in management. And of course, someone with congenital nephrotic syndrome is not going to be cured with steroids. So the ultimate goal is really to try to, get them to be big enough for transplantation.
Okay, thank you. I have kind of two questions that are along the same lines. One is, I've heard situations where people go into remission for many years and then suddenly relapse. Can you comment on ways to prevent spontaneous relapses? And then the other one is along the same lines, been in remission for 5 years, what are the chances of a spontaneous relapse?
So usually after 2 years of being, at least for childhood nephrotic syndrome, after 2 years of being in remission and then off immunosuppressive therapy, so off all steroids, Prograf, any other immunosuppressive therapy that you received, we consider that to be cured of the nephrotic syndrome. However, as in everything in life, there are exceptions to that rule, and I definitely have seen really a handful of children come back later on in their young adult years calling the pediatric nephrology clinic that they've had a relapse. So it can definitely happen, but I would say it happens so rarely that we really counsel people that they're cured and that they don't need to be dipping their urine anymore, even when they're sick, which can be a really hard habit to break. It just is very, very rare. Now, why it happens, I wish we knew. I mean, we all wish we knew exactly what the triggers were so that we could prevent them. Obviously, it's something that's triggered the immune system to wake up again and start making, this nephritic factor. Sometimes it's a cold or, a cough, some type of viral infection. Cancers can definitely do it as well, particularly in middle-aged people. But usually then you're dealing with a different type of nephrotic syndrome and not just your, the classic minimal change disease, but not necessarily, there are lymphomas, leukemias, those kinds of things that can do that as well. But again, just to be really reassuring, the vast majority of the time when you've had a remission for 2 years and no relapses off all immunosuppressive therapy, we genuinely can consider that to be cured.
Along those lines, another question we have is, my 5-year-old daughter has had FSGS for 3 years. I was initially told that this is a lifelong disease. Is it possible for a person with FSGS to outgrow it?
So, again, we don't biopsy every child with nephrotic syndrome anymore. You know, we only biopsy ones who are steroid resistant or who may have some other indication like side effect to medication or something like that. But not every child gets biopsied with nephrotic syndrome, and so could potentially some of those children who respond to steroids who outgrow it have FSGS? Sure, because it only takes one glomerulus on that biopsy or in the whole kidney, and you've got 1 million in each kidney, to make the diagnosis of FSGS. So it's certainly possible. However, we know that if you've been diagnosed with FSGS, the chances of you outgrowing it and coming off immunosuppression altogether is very uncommon. And usually it is a lifelong chronic condition.
Thank you. What is considered remission, which is a really good question?
So remission is if you're dipping negative or trace for 3 days. That's it. And that means that you're not spilling the protein in the urine. Your filtering units are healed. And if your filtering units are healed and you're not spilling that protein, then all of the other things that we find in the blood go away. You've got the sponges in the bloodstream that hold on to fluid, so you're going to get rid of all that extra fluid. Your liver is not trying to kick out more albumin, so the hypercholesterolemia goes away. And that's remission.
Can you talk to the protein creatinine ratio as well in measuring remission?
So protein creatinine ratio is an estimate of the day's worth of protein in the urine, and it actually does a really great job. We know, particularly in children and young adults, that during the day you can spill a little bit of protein during the day. That can be normal, just related to being upright. But if you're spilling it first thing in the morning after you've been in bed all night, that's not normal. And so that's why we obtain a first morning urine to eliminate the position changes that can affect protein in the urine. And then we calculate this ratio. And the ratio, so if you just do a urine dip, the concentration of the urine can play a role into what color everything lights up. So if your urine is already super concentrated, then you could dip positive for protein and not really have a significant amount of protein in the urine. And that's because creatinine is excreted by our kidneys as well, and it's a marker of kidney function. And we excrete the same amount of creatinine every single day. That's why our blood levels of creatinine remain stable. They don't go up as long as our kidney function is normal. So if we're peeing out an expected amount of creatinine in the urine every day, then we know that if you have a really high concentrated urine, so less water, your concentration of creatinine in the urine is going to be high. And so you can actually divide the two, the protein by the creatinine, and come up with this ratio. And the creatinine in the urine just normalizes that protein. And it'll give you a number instead of just the 1 plus 2 plus 3 plus. That's just more of a qualification, not a quantification. And that number that's normal is less than 0.2. And that equates to less than 200 milligrams of protein in a day. If you have a urine protein creatinine ratio greater than 2, that's equivalent, or should estimate approximately 2 grams of protein in the urine in a day, which in a pediatric patient is relapse. In adults, sometimes you'll get different numbers like 3 or 3.5. But essentially, you know, you have a protein creatinine ratio greater than 2, and that's a pretty significant amount, and it means protein, a lot of protein in the urine.
Thank you. Here's another question. It reads, hi, I was diagnosed with FSGS at the age of 25. I've been living with it for 2 years now. I take blood pressure medication along with cholesterol medication. My condition has not gotten worse, but my cholesterol is still high. Should I be concerned?
So some of that is out of your control if you continue to have protein in the urine. And in fact, you know, our goals are not necessarily, I mean, if we can normalize the cholesterol, that's great, but that's often not the case. And so a lot of times we just aim for lower, you know, because again, it has to do with our body's response to spilling protein in the urine. So if you're still spilling protein, it can be an uphill battle to fight the cholesterol. So again, our goal is not necessarily to normalize the cholesterol, but to lower it. and that can be done through statin medications, certainly fish oil, dietary, but some of it is out of your control. Did I answer that question, Kelly?
Yes, you did. And I was going to mention the fish oil, so I'm glad you did, because I know that has really helped some people rather quickly. Okay, another question, is there any benefit in doing allergy testing? Food allergies run in the family.
So I think the big question is if you're on prednisone or not, because if you're on prednisone, then you're not going to have the same response to the testing as if you're off the prednisone. And so, really, I don't know of an allergist who would even do testing while you're on prednisone because of that fact. But if you're off the prednisone and want to do the allergy testing, I don't think it's necessarily a bad idea. I think theoretically, and I've had people ask me this before, is if you do testing for allergies and you stimulate your immune system through the testing of the allergies, is that going to stimulate the immune system to start a relapse? I don't have the answer to that. I don't know if anybody necessarily has the answer to that. It's theoretical. But I think at the end of the day, if you're really concerned about allergies and you're off the prednisone and you're aware of the risks, you should do it, because if you find out what the allergies are, that could be helpful.
All right, and we have one more question here, so I'll just go ahead and say last call for questions. If you have any questions, go ahead and type them out now. This last question says, is there any kind of drug similar to DMARDs used for rheumatoid arthritis that can prevent the progression of nephrotic syndrome if given early on? Or is there any research being done in that area? Yeah.
What is it again, Kelly?
It says, is there any kind of drug similar to DMARDs that are used for like rheumatoid arthritis?
Oh, okay. So those are disease-modifying anti-rheumatic drugs is what they're talking about. So, it's like anything that we use in nephrotic syndrome. We kind of steal it from our the other autoimmune type disorders, which we brought up before. And so, I think they're on the horizon, particularly the antibody type drugs. So yeah, there definitely are. These are going to be off-label uses, and they're going to be drugs that you're going to have to sit down and really discuss with your doctor. But and of course it's outside kind of already. We've talked about first-line agents, second-line agents. These are kind of third-line agents.
Great, thank you. And kind of in the research world, they call that repurposing drugs, and there are pharmaceutical companies out there looking to do that all the time. So I think the more awareness we can bring to the rare disease space and to FSGS and nephrotic syndrome, the more companies that will start looking at those type of correlations between autoimmune diseases. So, all right, this is actually, we're going to go one more question because I think it's worth talking about. Any benefit to gluten-free diet in children with nephrotic syndrome?
Yeah, I mean, I get asked that question all the time. I have to tell you, I've taken care of 2 kids who, before they were diagnosed with nephrotic syndrome before I had ever seen them. And then it became clear later on that they actually didn't have nephrotic syndrome, they had celiac. And their presentation was super similar because their albumin would drop, they would get swelling, particularly abdominal swelling. And then as soon as you put them on prednisone, because prednisone can be helpful, in celiac, it goes away, and so it's just that nobody ever really got a great urine specimen because they were little and all this stuff. And so, I've had experience where people were actually in celiac and they didn't have nephrotic syndrome. This happened twice. Other than that, I have families try the gluten-free diets. I have to say I've never seen it help. You know, I don't mean to be discouraging, and I think if you can do it and you want to give it a try and make sure that your kid is getting the child is getting the nutrition that they need, or you yourself is getting the nutrition that you need, then I don't think there's any harm in trying it. But I also think you have to weigh that with another dietary restriction, because the low sodium restriction is so critical and so important, that you start throwing on there a gluten-free diet, and oftentimes gluten-free foods actually are pretty high in salt, that it can be very difficult to manage, very difficult to make sure that you're getting the nutrition that you or your child needs. So I don't think it's harmful necessarily to give it a try, but at the same time, it can definitely be an added stress, and I can't tell you that it's a slam dunk that it's going to help.
And I always like to point out too, because just speaking from experience, if your child's kidney function is at all affected, like if it's not normal, it can also be dangerous, because the gluten-free diet tends to run higher in potassium, and we ran into a problem with our daughter and trying a gluten-free diet when her kidney function was compromised. It actually made her potassium dangerously high. So it's always something to consider as well. All right. Well, I just want to tell Dr. Banks, thank you again for joining us. We really appreciate you taking time out of your day to spend with NephCure and our patient families, and I know that they will find this webinar extremely helpful. And we do have 2 more Ask an Expert webinars coming up, one in July. We'll talk about complementary therapies, in October, a very important subject, depression and chronic illness. And then I also want to point out, if you are in the Bay Area, in Charlotte or Houston, we have regional nephrotic syndrome symposiums coming up that are free to patient families and very informative. I would encourage you to visit our website and register for those. And again, all of our webinars are recorded and can be found on our YouTube channel. And I'll email out a follow-up of that after we're done here. So again, thank you everyone for joining us. Thank you, Dr. Banks. We really appreciate your time, and we hope to see everyone soon. Thank you.
Thank you, everybody. Bye.